What up, Z-Pack?
Hey, what's
It works. We were fiddling with this Wi-Fi, and it's like, why doesn't this work? Two doctors trying to decipher.
Exactly.
And we're in the Silicon Valley, so we're trying to do IT, and it's like, and we're both Indian, so we're like, what? Call your cousin. Your cousin will do it. He'll put it up. Anyways, guys, I'm gonna wait for a few people to cycle in here, and we're gonna introduce our guest today, which I'm really excited to have Dr. Ronesh Sinha with us today. He is not just a friend and a colleague. He's a physician here at the Palo Alto Medical Foundation in the Bay Area of California. He's an internist. We've known each other for quite a few years, and he's admitted patients to me, and I've cried about it well on a decade, I'm sure. And the reason I wanted to come here to Palo Alto and interview Ron, have him on the show, not really interview him, but have him spread his wisdom, is that he's doing some really, really, really exciting work in the space of how can we reverse lifestyle-induced illness in our population?
Right.
And just tell me a little bit about yourself and how your background in training and how you got into this, and then we'll dive right in.
Hey, sounds good. So I'm an internal medicine doctor. So I trained at Tufts University, did my residency training at Cedars-Sinai, came out to the Bay Area to practice with Palo Alto Medical Foundation. I set up shop at our Redwood Shores clinic right next to Oracle. And what I started seeing was, being a high-tech company, I saw a lot of 30, 35, 40-year-old engineers coming into my practice. And I started noticing that despite a lot of them following standard guidelines on healthy eating, many of them were getting pretty sick. I mean, I was seeing 30, 35-year-olds with new onset diabetes, heart disease, all of that. And what I was doing was I was just sort of handing them a handout on the Mediterranean diet or some standard nutritional stuff. And
that stack of pamphlets
that
where you're
stack
like,
of
read that,
Yeah, right.
and patient number 12 is up
exactly.
next. Yeah.
And if you're not, better in 3 months, I'll put you on a statin. That's kind of the general approach that we learned in medical training. So interestingly, we started seeing that pattern. And what I started doing too was I started following my own numbers in the same way, following the same advice. And incidentally, I ended up developing metabolic syndrome, which is a real risk factor for heart disease.
And for those who don't know that term, metabolic syndrome, could you just elaborate on what that is?
So metabolic syndrome is a constellation of different risks that increase your risk of heart disease and diabetes. So the typical parameters are high cholesterol, particularly high triglycerides, and low healthy cholesterol, elevated waist circumference, blood pressure, and blood sugar parameters. So here I am giving advice to my patients, and I'm following the same advice, and I'm actually getting sicker. So at that point, I'm like, okay, traditional training is really not doing the trick. In the meantime, I'm also going out to companies talking and giving advice on this stuff, but I'm not really seeing the results that I should. So the minute I started developing those issues, I'm like, okay, I've got to really think outside of the box and look outside of traditional guidelines. And that's when I really started delving deeper into the science. Because, how many hours of nutrition training did you get in medical school or medical training? Yeah, pretty much.
Yeah, it was how to read the recommended daily allowances on the back of the box.
It
was learning the food pyramid, which we all know is wonderful.
Yeah.
Perfect. And, eat less, exercise more.
Exactly.
Yeah.
So that's pretty much what I was doing. But after applying different approaches outside the traditional realm, I started seeing amazing results in myself and my patients, and that just became so gratifying. So it kind of took me on a different journey of, okay, I've really got to customize and tailor nutrition advice for these patients because clearly they're not benefiting from the standard dogma.
Now, you said a couple of things that I think I want to emphasize, Z-Pack, because recently we've been talking about there is no one-size-fits-all diet.
Sure.
There's no one-size-fits-all approach. Now, what Dr. Ron figured out was that for South Asians in particular, there's a certain phenotype or genotype or type that responds to a certain set of guidelines a little better.
Yeah.
And that may actually apply to a lot of non-Asian populations as well.
Right.
But it doesn't apply to everybody, and he never is saying, here's the diet that's going to work for you. He's saying, let's kind of figure out what diet is going to work for you. And you experimented on yourself, and now you have a sort of an algorithm that works well for you and for a lot of particularly Asians and South Asians.
Yeah,
so
absolutely.
Chinese, Vietnamese, South Asians, Indians, etc.
Yeah, totally.
But the parameters are good for many of us to think about.
Yeah.
So please, I interrupted you.
No,
so
absolutely.
You got into that.
Yeah, and so the whole culture piece of it, and you bring up a great point with the culture, is obviously diabetes and heart disease is a worldwide phenomenon, but certain cultural backgrounds develop those issues at lower set point numbers. So basically, it just takes 8 to 10 pounds of excess weight for a Chinese or an Indian to develop diabetes or heart disease, where it might take 20, 30 pounds for somebody from a different ethnic background because of body composition differences. And the problem is when those folks walk into the clinic, when a doctor just looks at the standard sort of algorithm for this is a normal body mass index or this is your risk, many of these guys fly under the radar. Their doctors tell them, hey, you look great, you're skinny, you've got a normal body mass index, so you don't need to do anything. And lo and behold, they end up having heart disease or diabetes after that.
How many of us who are in the healthcare profession have seen this happen? You see somebody's, their numbers are not terrible, at least by our particular standards of how we look at numbers.
Yeah.
You look at them and you're like, you're not really obese.
Yeah.
You know, maybe a little pudge in the center, not too bad.
Yeah.
And, you know, maybe you don't exercise, or maybe you do actually exercise a lot. You're doing a lot of aerobic exercise.
Right. Yep.
So maybe everything's fine. And then they have a massive MI.
Exactly.
Or they end up getting diagnosed with diabetes or pre-diabetes, or they get a cancer, or they
Yeah.
have an inflammatory illness, and you just go, what is going on? And
That's right.
I would see it constantly.
Yeah.
And in fact, anytime someone will come to the emergency department in the Bay Area when I was a hospitalist, if they were South Asian, Indian, or Chinese,
Yeah.
I would take it very seriously.
Yeah.
Even the kind of typical heartburn complaints that maybe a Caucasian male patient might be stress related or something else.
Yeah.
I would, in an Indian patient, I would go, you know what? We're going to do a
Absolutely.
stress test.
Yeah.
Yeah.
Totally, yeah.
Yeah.
I mean, that's why they have the highest incidence of heart disease in the world. China's a close second right now.
Is that
We're
right?
seeing that, absolutely. So, yeah, and it's a lot of those risk factors. And a lot of it is just a lack of knowledge. And unfortunately, in this case, until medical science catches up, it's really up to patients to really understand what their numbers mean and not leave it up to doctors who've been trained in a more mainstream Western fashion. Not to rag on my doctor colleagues, but it's just, you know.
Well, and I want to unpack that a little bit because, you know, we talk about empowering patients, and those of us in the Z-Pack often will lament the downside of Dr. Google and people trying to self-diagnose.
Yeah.
But this is different. This is giving patients actually tools to understand their health that they can then bring to their doctor.
That's right.
And sometimes they're educating their doctors, right?
They are, absolutely, yeah.
And that can be a little intimidating for us.
Yeah.
Especially in this town.
Absolutely.
Yeah. So you got into that and you started learning some things about nutrition and physiology that maybe we certainly weren't taught in medical school.
Yes.
And what did you learn?
So one of the key things you brought up, a really important point, is I think a lot of the focus has been on exercising harder. And I think exercise is absolutely a critical part of health and wellness. But what I saw is a lot of these individuals come to my clinic were in great shape from a cardiovascular standpoint, but they weren't necessarily fixing their diet the right way. So now with all my patients, 90% of my time is fixated on the dietary element. The majority of the Asian Indian patients that would come to my clinic happen to be vegetarian. And I found that with their lipid profiles and numbers, they had the most abnormal numbers, which was shocking both to me and to those patients.
Yeah. So. And there's been a lot of talk about this.
Yeah.
How can they be vegetarian and still have these problems with high triglycerides, metabolic syndrome, cholesterol abnormalities? But even if you don't even see the cholesterol abnormalities, you're seeing the coronary disease. Yeah. And then many people will say, well, it's because they're cooking in ghee and clarified butter and trans fats and other sweets and things.
Coconut oil, all that stuff.
Coconut oil, is that the answer?
It's not, because a lot of these vegetarians, when I do their dietary intake, they're actually not cooking with those types of fats because they're very fearful of those fats, but they are eating a lot of the grain-based diets. And, you know, so do you know what the term IBDA means? You've seen a lot of IBDA patients, right? So what does IBDA stand for in the ER?
IV drug abuse?
Right. So in my practice, it's the Indian vegetarian dietary abuse, basically. So it's
Whoa.
taking...
I like that.
So that's IBDA.
You are committing IBDA. Why are you doing this?
Exactly.
Yeah, I love it.
I mean, there is an incredibly healthy version of the Indian diet because all these things you see in mainstream nutrition, turmeric, coconut oil, they're all coming from the Indian diet.
People are asking about turmeric.
Yeah,
should I be eating turmeric? Should I be...
Phenomenal
You know,
stuff.
are Filipinos affected by this?
Yes, absolutely. Great question.
Yep.
So those are wonderful parts
Terry
of it.
Dickey. Yeah.
But unfortunately, because of all this fear about fat, many of our traditional Indians have ditched ghee and coconut oil and a lot of these foods that can actually help heal them. And instead, they're eating abundant amounts of the actual food that's generating the insulin resistance, which is excessive amounts of carbohydrates.
Now, recently we got into a bunch of battles with the vegans because their doctors, who also have books and also have websites like yourself and also consult, are saying no, the answer is that these guys are eating too much fat and too many processed foods, and that is what is triggering the diabetes, the high protein, high fat diet, the Western diet. Now, but that's not what you're seeing in Indian population.
Absolutely not.
Yeah.
When you get them to actually lower the amount of carbohydrates and it's more compatible with their energy output activity, we find that when we reintroduce those healthy fats, it's phenomenal how well they do, subjectively from an energy and performance standpoint, but also one of the numbers I track in many of my patients is that C-reactive protein. So you might
Very
know it's called
important
CRP. So it's a marker of inflammation. And typically in med school, we're taught to basically, we would use that to see if a patient needed to go on a statin. But from a lifestyle perspective, I see so much elevated C-reactive protein. And a lot of it, most of it is really coming from lifestyle. And interestingly, when you get them to eat the right diet and you reintroduce healthy fats, the healthy fats are anti-inflammatory. So I will typically see that C-reactive protein go down as we do these things.
So by healthy fats, we're talking about in the polyunsaturated fat space, like omega-3.
You got it. Yep.
In the saturated fat space?
Yeah. So in the saturated fat space, things like clarified butter and ghee, grass-fed butter, so coconut oil. These things are all great sources in moderation.
Why is it theorized that grass-fed butter might be better than standard butter?
So grass-fed basically because these cows are being fed grass, so they get more healthy fats from the grass. So CLA is conjugated linoleic acid. It's got great anti-inflammatory properties. And there's been at least 6 to 7 studies that show that healthy sources of dairy fat will actually lower diabetes risk. And a lot of the theories are not just lower inflammation, but we actually see positive benefits on gut microbial health. So there's a big connection. You might have talked about this before.
A little bit. Yeah. And what I would say is it's interesting because when I was reviewing What the Health, the documentary that I criticized, I accused them of cherry picking data in a confirmation bias kind of way. So in other words, they would just find all the few studies that showed that dairy caused diabetes or is associated with diabetes. Yeah. Now the question is, are we doing the same thing on the other side, or are you pretty confident that this data shows for this population?
Good point.
Yeah.
So this, nutritional studies are inherently confusing and conflicting.
Yeah.
So as much as I read through these studies, every individual is their own study. And the way I use the numbers is if I start somebody on a lifestyle plan, I will check before numbers, lipids, glucose, C-reactive protein possibly, and then we put them through 2 or 3 months and we recheck the numbers. And that's where we'll see. So some people, they introduce more of healthy fats in the diet and we see C-reactive protein go down. All their numbers are getting better. Other people introduce those fats and they're saturated fat sensitive. Because of some genetic markers, there's 3 key genes that can cause that, and that can cause your LDL cholesterol to go through the roof. And in those people, I'm clearly not going to say eat as much ghee and coconut oil as you want. So you've got to personalize that part of it.
So it's interesting. So I'm going to tell a little personal story. So when I've always been 5 to 10 to 15 pounds overweight. Okay. And I'm a small guy, like I'm 5'5", so that's a good percentage of my body weight. Yeah. I'm also South Asian, Middle Eastern. So recently, as I got older, I noticed my hemoglobin A1C, my measure of insulin resistance and prediabetes was going up to the point where it became borderline 5'7", 5'8", 5'9". Yeah. And I said, And for me, I said, okay, I'm going to try intermittent fasting. Then I'm going to try an extreme low carbohydrate ketosis diet. Okay. Now, for me, now what I noticed, and I did this in conjunction with Peter Attia. He measured NMR, lipid counts, everything. And what we found is when I ate a high saturated fat diet, just like you're saying, I was one of those saturated fat sensitive people. Yeah. My LDL went from 80 to 165. And my particle count went high. So, but my HDL went up. My triglycerides were 34. So these are all good parameters. So I think what Dr. Ron is really trying to impress on you guys, and I agree with, is there is no one size fits all. You have to experiment on the N of one, the patient.
Absolutely. And you want to diversify your portfolio. What I mean by that is there's so much press about saturated fat that I have patients that are eating jars of coconut oil all the time.
Now they think, coconut oil,
totally. But still, as much as right. And we don't really we have enough studies to show that coconut oil is probably not having an adverse effect on lipids, but it's not as heart protective as monounsaturated fats like olive oil. So you want to diversify. So if I saw somebody whose LDL numbers went up, I wouldn't say ban saturated fats, but let's emphasize the extra virgin olive oil. Let's do avocado oil and a little saturated fat on the side too.
So for me, that's exactly what I did at Peter's advice. And I ended up subbing the coconut oil I was cooking eggs in the morning with olive oil. And I was still eating the eggs. Yes. And then for lunch, I'd have sardines poured in olive oil with a bunch of Tabasco. Beautiful. And dinner, I'd have a Mediterranean type thing with very low carbs, very low grain, but a lot of vegetables, fresh vegetables. Totally. My LDL went from 165 down to 80 again. My HDL stayed high, and my triglycerides were still like 40. Yeah. So you have to experiment, and honestly, that's a Mediterranean, a kind of a low carb Mediterranean version.
Yes. Yeah. That's true. I wanted to bring up also, you mentioned the ketogenic diet, and definitely I've had a lot of patients go on that and do really well.
Yeah.
But I got to say that some of my patients, we see their C-reactive proteins actually go up as a result of the ketogenic diet. And especially I've seen it in women, because women, just from a hormonal perspective, sometimes cannot endure prolonged low-carbohydrate dieting, especially in the face of increased physical activity. And often I'll see C-reactive proteins go up, and often I'll see weight loss actually not get stalled, or they actually end up gaining weight back. So another example, because I think ketogenic diets are great, but I definitely in my clinic do see some side effects from that as well.
I think that's tremendous, because people, some people like to pigeonhole me into some kind of ketogenic camp. I'm not. I think that there's a lot of upside and downside to every kind of diet for every individual, and it's exactly that. Now, you had mentioned C-reactive protein and measures of inflammation.
Yeah.
I think a lot of people don't understand that inflammation, if not being entirely necessary, it's nearly necessary to have coronary disease and some other syndromes. So you can have high circulating lipids and bad cholesterol, LDL, and that kind of, but if you don't have inflammation in the vessel wall, that stuff never gets in there and causes plaque.
Absolutely.
So you kind of need this constellation. So if diet is affecting inflammation, and genetics may affect inflammation, then it's important to pick that diet that works for you. Now, when I was doing this ketogenic diet, my CRP was undetectable.
Okay.
So the problem is I never had a baseline.
Yeah.
So I don't know what it was before.
Sure. Right.
And I need to recheck it now on a modified Mediterranean.
Yeah, absolutely. And one key point about C-reactive protein is when it's elevated, it's significant. But I've had plenty of normal C-reactive protein folks with autoimmune disease and heart disease. So don't be falsely reassured by like a normal C-reactive protein. It's one marker, but it's imperfect.
Got it. That makes a lot of sense. Now, let's see. There were a couple things in your book. And so Ron has a book called The South Asian Health Solution.
Right, yep.
And I read it because he's a pal. Normally people throw me these books when I go to talk, and they're like, oh, here, I got the glucose solution, or how vegetables will save your life. And I'm like, oh, it's going to go on my bookshelf and I'm not going to look at it. But Ron, being a pal, I said, you know what, I'll at least read the first page. I read the first page, and I read the second page, and I was like, oh my gosh, you really did kind of understand, I think, what's going on, especially in South Asians and Asian populations. And this is a huge growing problem nutritionally. So in that book, you talked about things like the Metabolic Six Pack.
Yeah.
Can you describe for these guys what a metabolic six-pack is? We talk about having a six-pack of abs, but a metabolic six-pack is a series of markers that help you understand your risk for diabetes, heart disease, etc.
Exactly. Yeah. And the foundation of it is really the metabolic syndrome criteria, but I made some modifications to that. So the real criteria on your lipids, doctors tend to focus a lot on LDL cholesterol, and LDL cholesterol is significant. On a standard panel, it has less significance. A standard panel just checks what's known as the LDL-C. But with metabolic syndrome, it's more of a triglyceride and HDL issue. So you look at your triglycerides and HDL. Those are two of the parameters. You look at glucose parameters like your A1C, which measures your average sugars for the last 3 months, and a fasting glucose. You look at blood pressure, and you also look at body metrics in terms of waist circumference. So those are the numbers we're looking at. I really spend a lot of time, as you know in the book, teaching people, including doctors, how to read the lipid profile, because that's where I see most of the money. And the thing is, we always equate type 2 diabetes risk with the glucose level. But often we can catch symptoms way before that. So we call it pre-diabetes, right, if your glucose is borderline. But I call abnormal lipids pre-diabetes because if you catch the triglyceride HDL abnormality, that precedes glucose problems by up to 10 years.
Oh, really?
So that's why I tell folks, so one simple trick for you to know is just take your triglyceride level, divide it by your HDL. We call it the triglyceride to HDL ratio, and aim for that ratio to be less than 3.0. If there's one thing you take away from this presentation, know that ratio, because many of my patients that have been missed for heart disease risk, if they knew that ratio, if their doctors knew it, they could have been saved, because they would have been given the right types of lifestyle recommendations. So that's one critical part of it. But again, catch it before the glucose goes up. And I have a lot of heart disease patients that their glucose is normal, but it was that triglyceride to HDL ratio that actually caused the inflammation and the vessel calcification and the actual plaque in heart disease. So just because your glucose is normal doesn't necessarily mean you're going to be fine as well too. So it's important to really understand these numbers and put them into context.
Let me back up one thing that you said. The triglyceride to HDL ratio caused this. More, you probably mean it's a marker for that.
You're absolutely right.
So it's a risk marker for
exactly.
it. So we don't know that the ratio has anything specifically to do with causation, but it is so closely
it's one of the critical markers.
Right.
Exactly.
Right.
No, but you're right. If you have a abnormal ratio, but let's say the other parameters are fine, maybe inflammation's subdued, you're doing other things, meditating, etc., then maybe that ratio alone isn't going to be enough to trigger that heart disease.
You mentioned meditation, so this is a part of the sort of cascade stress. Part of the cascade, especially in South Asians.
Oh my gosh, yeah.
But you're not being a doctor. Why didn't you go to school? What are you doing?
Right, exactly.
You're going to be on the street, fatafat.
So in Silicon Valley, I end up seeing a lot of hard-driving Type A++ folks.
No,
right?
Not here.
I know. Yeah, exactly.
Come on.
But
I can't even drive on the damn street without freaking out. Like coming from Vegas, we're all chill. Over here, it's like, hey,
totally.
buddy! Middle finger.
God.
Yeah.
It's crazy. But one thing that I've really seen quite a bit of is I'm seeing individuals that had normal numbers, glucose, lipids, body comp, a lot of execs that are training every single day, and they're having their first heart attack despite all of that.
Yeah.
And after seeing that enough times over the years, I'm like, I got to take my stress seriously too, because just having an accelerated nervous system on a regular basis, that is independently enough to actually trigger plaque formation. I didn't appreciate that till I started seeing that over and over in my practice.
And there were some other interesting things. I want to get to these comments too, because
Yeah,
they're really
sure,
good.
let's do it.
Okay,
Yeah.
I'll tell you what. Let me ask one comment, then I'm going to get back to.
Sure.
I want to ask you about PCOS and women.
Yeah.
And some of the other things you're seeing in the female population in particular
Yeah.
that relate to insulin resistance and this whole idea.
Yes.
And again, I think the crux of what Dr. Ron is saying is, if I'm understanding correctly, is that we're recognizing and mistreating insulin resistance, which is a core of a lot of disease.
Right.
And inflammation is a piece that relates to that, and stress is a piece that can cause that, and it all ties in then to the outcomes, which are diabetes, coronary disease, hypertension as a manifestation of this, cancers, et cetera, et cetera, et cetera.
Yeah.
So one question was, you had mentioned that there are 3 genetic markers or mutations for the saturated fat sensitivity. Do we know what those are?
So there's probably multiple, but ApoE is one of them.
Yeah.
There's one called the FTO, and then there's one also known as PPAR, PPAR. So those are a couple of the markers that you can look at. I've never done 23andMe in myself. I don't order it in my patients. I think the information is useful, but quite simply, if you just did that saturated fat trial where you have patients modify their diet and recheck their lipids, it's pretty easy to sort of intuitively tell that somebody's saturated fat sensitive. But it is becoming more accessible to get these genetic markers checked, and it might give you some additional information.
I actually did it for me, and I found I was ApoE 2-3 heterozygous.
Got it. Yep.
So I have some protective potential benefit and some just neutral.
Sure.
But the 4 allele is the more dangerous one historically.
Right. Exactly.
So ApoE 4 heterozygotes, they manage lipids in a way that's very damaging potentially, especially saturated fat.
That's right. Yeah.
Excellent. So we were going to talk about polycystic ovary women, what you're seeing, especially in Indian women population.
Goodness, yeah. So PCOS, or polycystic ovarian syndrome, is a condition that is, the root cause is insulin resistance, just like with diabetes. And a lot of cultures, especially South Asians, Filipinos, folks that have a higher incidence of insulin resistance, can develop this predominantly. And it's interesting because a lot of adult women that I see never knew that they had the condition when they were younger. And PCOS, in addition to increasing diabetes and heart disease risk later on, causing infertility, the other issue with PCOS is basically obesity, acne, facial hair. There are a lot of emotional stigma things. So a lot of girls that were teens that had this condition, they were teased by boys, they went through depression. So it's really a devastating condition, and much of it can be reversed with lifestyle changes. So I've seen some teenage girls or women in their early 20s, and we put them on the right sort of diet, and they're able to get off all their medications and reverse it completely. They're able to conceive as well too. And enough, women are not told that this is actually a primarily lifestyle-induced condition that can be reversed with lifestyle changes.
How firm are you on that?
I'm pretty firm on that. I've seen enough. Again, with any condition, diabetes, PCOS, insulin resistance is potentially reversible. It's more reversible than I'd ever thought. But definitely, I'm not going to say that every case is, because there can be some other markers.
And I think there are some people.
Yeah,
exactly right.
Yeah.
Some people really struggle. They do everything right, and they still have this. And it's a complex, multifactorial. So one thing I want to clarify is that I don't think even the title of our talk today is diabetes reversible? The answer is yes, in some cases, with the right approach for you. So we're not trying to paint everything with a one-size-fits-all brush. Yeah. And that's what I liked about your book, too, is you were quite permissive in the book of different approaches.
Sure.
Let's see if we can see some comments here. because I think a lot of people are really interested in the PCOS thing and
Sure.
hypothyroid and those kind of things. Are you seeing any of that?
I do. I see a lot of hypothyroidism. Okay, and one of the things I'll say about hypothyroidism is, again, that's one of those conditions. You see a typical patient in the office, you diagnose them with a thyroid TSH test, and you put them on Synthroid for the rest of their life. We treat it as an irreversible condition.
Correct.
A lot of hypothyroidism is reversible, and because one of the most common cause of hypothyroidism is Hashimoto's thyroiditis, which is an autoimmune attack on your thyroid gland. And a lot of that immunity is coming from lifestyle changes. I hate to be a broken record, but again, inflammation. So many of these folks, as much as I never really jumped on the gluten bandwagon, there's a huge overlap between gluten intolerance and thyroid disease. Multiple studies on that.
You can leave this show right now because you know the Z-Dog show is all about lowering gluten awareness.
I'm out.
He's out. So tell me more. Tell me more about the gluten piece, because is it a trigger for inflammation in certain people?
It looks like people that have that genetic tendency.
That have that tendency, right.
And on all my patients, if they've got signs of, especially in combination with other autoimmune factors, a gluten-free trial is so easy to do. And I'd say, again, this is not a guarantee, but I'd say in a pretty significant portion, we do sometimes see some recovery. We see decrements in their thyroid medication, we often see, but there definitely is a significant lifestyle strategy to thyroid that can be very helpful. And to me, hypothyroidism is just a sign that we are more susceptible to inflammation, because it is an autoimmune process, and likely that's a sign that your immune system is active and might be targeting other parts of the body as well.
Lana Hicks says, every individual is their own study. Thank you for this. We'll be glad when more docs think this way and personalize treatments more. I mean, I think that's the bottom line, what we're trying to say here.
It absolutely is.
Everybody's an N of one. Everybody's their own study. And that's why, again, I get very upset when anyone tries to paint anything with one single
Sure.
thing.
Yeah.
I like the principles Dr. Ron is saying, but not all of them are going to apply to every single person. So there's a plenty of hypothyroidism that's not reversible without medications. There's plenty of diabetes that's going to require medication. And we both agree on that.
Yeah.
Go ahead.
No, sorry. One thing I was going to tell you too is individuals also change as their body composition changes. So I might be highly insulin resistant. So when I say that, what I mean is maybe I can only tolerate 100 grams of carbs when I first, start off on a plan. But as I lose body fat, especially that visceral fat, as I gain guns like you, which is basically, those are pretty impressive.
It's not easy.
Right. So once you change
Your $5
that body
is in the mail.
composition, right, exactly, all of a sudden we see that folks can handle 150 or maybe more grams of carbohydrates. So our body metabolically can change and become more insulin resilient.
Insulin resilient.
Yes.
Explain that to the Z-Pack, because when I read this in the book, I was like, I'm going to start doing squats. I'm going to increase my leg muscles. Because why? Because they're parking spaces for glucose.
Yeah.
They can store glycogen, which is glucose in muscle and in liver. And to do that, you increase their capacity.
And their ability to convert glucose into ATP energy. So you want to make... So many patients that I see, they might do their typical 20, 30 minutes on the elliptical. Maybe they'll do some upper body, work on the anterior muscles. But I tell them, when you get to the gym, you warm up and you work on the largest storage containers for glucose, which are your legs. And because we sit so much, we're losing, we're seeing sarcopenia or wasting in muscles in young folks because they're sitting so much. So I'm like, target the legs first, because that takes the most motivation to actually exercise your legs, and then do your other body parts after that. And we see significant improvements in insulin resistance.
You don't hear this as much. By the way, that word sarcopenia, if you don't think I'm using that at the beach when I kick sand in some little skinny kid's face, you got to know. Hey, sarcopenia weenie, clear those chicken legs.
Right. Yep. I got teased about the same thing.
I'm that guy. You know that.
Yep.
I'm a bully. I'm like a very short, very scared Vin Diesel. Let's read some comments. Nice. Good point on the stress factors. I should avoid rush hour driving, apparently. Candace Mulholland. But how do you talk to your patients about stress?
So a few things. Stress is unavoidable, but what I tell people is stress is kind of like a pressure cooker. It accumulates throughout the day, and we need to find practices and strategies to let off some of that steam. That could be some breathing, it could be getting out in nature. Whatever it takes, you've got to make sure you interrupt that prolonged stress that continues. And for some people, it's not just work and personal. They're also having a lot of physical stress from over-exercising. So typically a lot of my execs, what they do is they're working hard all morning, then they jump to boot camp at noon, then they jump back to work, and there's no space in between. So I tell people, if you've got an hour to work out, like do 40 minutes maybe of whatever you end up doing, but leave the last 15 or 20 minutes, just breathe, stretch, do yoga. Anything you can do to slow down that nervous system. For a lot of my folks that don't really catch the yoga meditation thing, they think it's too woo-woo, I will do some sorts of body sensor things. So heart rate variability, or HRV, is something I blog on a lot. There's some cool apps and tools that you can use to measure how your heart rate responds to stress, and you can train yourself to actually mediate that. So that's been a really powerful intervention.
That's really interesting. So maybe check out your website, your blog for that.
Yeah.
So Dr. Ron blogs. He wants you guys to have this information. He is not hoarding it, and and I put the name of his book in the comments, The South Asian Health Solution, correct?
Right.
And it's available on Amazon. I really enjoyed it as a way to understand better things like metabolic, glycogen, glucose parking lots, and the Metabolic Six Pack, and the idea that there are exercises to increase your reservoir and insulin resilience, as opposed to being so insulin resistant. The stress piece, the inflammatory piece, and then he has actual diet sort of options for replacing high carb components, inflammatory components, with stuff that's maybe more vegetable based. You're not really saying go out and eat a ton of meat and a ton of saturated fat.
Hey, listen, 50% of my patients are vegetarian, so I could not get away with doing that, right? But many of them, again, are eating the wrong version of that sort of vegetarian diet. I call them grainitarians, not vegetarians.
Grainitarians.
Right? Because they're eating overcooked vegetables.
Okay, what's wrong with overcooking vegetables?
So basically, you're going to lose a lot of the phytonutrient deficiency. If you've seen like a typical household Indian curry, I mean, it's like limp. It looks like it has erectile dysfunction, right? It's just completely limp. There's nothing going on with it, and so you end up losing a lot of that. So the minute a vegetable loses its color and consistency, you're actually losing out on a lot of the nutrients.
Why are you calling my curry? You're calling my curry limp only in front of everybody. I cooked it all day. I stewed it all day. Well, now all the nutrients are gone, Ma. All the nutrients are gone, and my LAD is 100% included. So that's a piece of it, and then the grainitarian piece is a lot of lentils, a lot of rice, a lot of naan, a lot of grains. And not a lot of things that cause satiety, that don't trigger insulin.
Right. Yeah. And the other thing, too, is that excessive amounts of grains. They've done studies. There was a study in 1972 that showed that Asian Indian immigrants, because they ate so many grains, they were developing nutritional rickets. So they were actually getting floppy, fragile bones from that. Because those grains have a chemical called phytic acid, which is an anti-nutrient, and that hangs on to vitamin D, magnesium, calcium, and zinc, and leaches it from your body. So we see a lot of premature osteoporosis. We see growth deficiency in kids, because a lot of Indian kids, especially vegetarians, parents are too busy. They're throwing flatbreads at them like Frisbees. Just eat this, and they're not getting the nutrient-dense foods. So now their growth stature, my wife being a pediatrician saw this all the time, would see a lot of growth deficiency and also early metabolic syndrome in kids as well, too.
Oh, yeah, I've seen it. We all see that. Dr. Harry, or my partner in crime on those, he sees that stuff at Kaiser. And whole lot of naan, yes, says Heather DC. Some people are going to fight you over this naan thing. Totally. Does the South Asian diet work for West Coast American whitish folks, Alicia Leilani?
I think it works really well because it's got a broader diversity of healthy fats. It's got the spices, which are really anti-inflammatory. So there's great parts of it. But I think eating a fusion diet is great. For a lot of my folks, I actually find, is me being Indian, the type of diet that really works well for me is some combination of an Indian diet and a Japanese diet.
Oh, interesting.
Because I found with more omega-3 and fish consumption, and the way the Japanese prepare rice is absolutely perfect. Because rice, if you actually cook and cool it repeatedly, it becomes a resistant starch. Less of it gets absorbed into your...
slower absorption.
And when you add vinegar to rice, actually, or the effects of vinegar, it actually lowers the glycemic spike after carbs. And genius-wise, basically the Japanese, when they make their rice, they actually make it with rice vinegar, and they have it cold. And they have it combined with fish and vegetables, so it really lowers that glycemic impact. So
because a lot of people will say, well, how could this be true again? Like some of the most long-lived cultures on the planet are very high carbohydrate intake in cultures like the Japanese or the certain aspects of the Mediterranean diet. But it maybe answers like this. It's the type of carbohydrates, the speed of which they're absorbed, the social stressors and community support people get.
Huge parts of it.
The fact that they're super active, so they have all the space to actually absorb glucose.
And they have sunlight exposure, so we see rampant. Yeah, sunlight exposure is critical for so many things, for emotional health, but a key part of it, for wrinkles, exactly. But also, it's where we primarily get our vitamin D. And I'd say 70-80% of the patients I see here in Silicon Valley are significantly vitamin D deficient. Now, vitamin D we think of with bone health, but vitamin D does a few other things. It's a potent anti-inflammatory. A lot of people call it a hormone rather than a vitamin. Lowers inflammation. It also helps with your muscles' metabolism of glucose. It helps convert glucose to ATP energy more effectively. So vitamin D is actually essential for those things. Again, it's not a big picture. People are not going to reverse diabetes by getting their vitamin D up to normal.
Don't go taking a bunch of supplements now.
Exactly, that's right. It's still lifestyle is a big part of it. But these small micronutrient deficiencies like vitamin D, iron, magnesium, etc., they can have an impact on insulin resistance as well too. So
excellent. Colleen Garvey says not all carbs are created equally.
Absolutely
I think that's spot on, right?
Yeah.
So people seem to think I have some aversion to carbs. I actually don't. I actually have an aversion to refined sugar. I have an aversion to white flour. I have an aversion to quickly absorbed carbohydrates like white rice that are cooked wrong.
Yeah.
Al dente pastas, semolina pastas are actually reasonably
they're
low
better on
glycemic
glycemic.
index. Yeah.
So one big point I want to make, so if you want to look up a study that's really fascinating, it was put out by the Weizmann Institute in November 2015. They took 800 participants and they basically measured all of their glucose responses to eating different types of starches. And the results were astounding because they actually mapped it to their microbiome, their gut bacteria. And they found that certain people would have a cookie and they'd literally have hardly any glycemic response at all. Other people would have the cookie and you have the expected response. Same with potatoes. They tested sushi and they saw so much variability based on the microbiome. So that's why a lot of us as doctors or as friends, I might tell you rice is bad, right? But I really don't know, you know, because everyone's microbiome, their genetics, the way they metabolize is so different. For some people, rice is the best thing they can eat. It's actually good for them. But, you know, if you've got insulin resistance, you're sedentary, you know, most people, rice is probably not the fuel of choice in the beginning. But just want to make the point that there's a lot of nuance to it in terms of how people handle starches and what their glucose response is.
Do you guys see why I'd rather talk to Ron Sinha about nutrition than almost anybody from that movie, What the Health? Because he is telling us that there isn't a single answer for every single person, and there's a lot of variability. And our goal as physicians is to try to nail down with that individual, not just what their genetics and their aptitudes are, but what's their cultural component of it.
Exactly, that's huge.
So what you know, what is it in Indian culture where the mom is like, "Oh, you're here, come, eat this, the sweets."
Yeah.
Like she's not successful as a mother unless she's shoved a ton of carbs in your
I've had
throat.
relatives cry when I don't actually eat the sweets.
Oh my
that's
gosh.
not bad. They get very emotional about it. It's like you were insulting them.
My mom gets like that.
Yeah, totally. So it's tough. It's
It's
a hard
tough.
road.
So it's a cultural. You have to try to figure out how to fit it in. You know, my mom got really pissed at me when we were coming through Fresno on our way to the Bay Area. I stayed with them for a few days, and I don't eat breakfast. Which, by the way, is that bad?
I love it. I actually recommend it for a lot of folks. And in fact,
not eating breakfast.
Not eating breakfast. For a lot of insulin-resistant folks, they've got elevated fasting blood sugars in the morning. So what I say is your body already made breakfast overnight. So why do you want to throw Wheaties and oatmeal on top of that, right? So do some activity, burn that off, and then wait till later. If people can be a little bit more restrictive earlier in the day, I don't mind them starching up at night, actually. You know, it actually works better from a hormonal perspective, helps you sleep better. But yeah, for you, that works great.
And that works well for me because I eat my biggest meal around the late afternoon, early evening.
Okay, great.
And I'll often cheat a little bit on the carbs and stuff. And what I find is I don't gain weight. I feel comfortable. My A1C is fine.
Perfect.
Now, my mom flipped her lid, and so did my dad.
Yeah, I'm sure.
Breakfast is the most
important
meal of the day. Have some oatmeal. Have some fruit. I'm like, the minute I do that, Mom.
Yeah.
I'm going to gain like 5 pounds because what's going to happen? I'm going to get hungry for lunch because I'm going to have insulin secretion.
Exactly right.
And probably my AM sugars are always around 98.
Okay.
That's where they live.
Right.
So, you know.
Yeah, totally key.
So there's no one side. Now, some people have to have breakfast. I think people who eat a more permissive carb diet tend to have to eat a little bit more frequently.
Right. They're driven by that hunger, insulin roller coaster. Yeah, absolutely. Yeah.
Boy, this has been fantastic. We've gone about 37 minutes now.
Wow, time flies.
I'm going to see if we can answer a couple more comments, and then I'm going to let Dr. Ron off the hook. But if you guys like what you see, hit share, hit like, let us know. We'll get Ron back on the show. We'll fly him out to Vegas or something.
Nice, sounds good.
It'll be,
totally.
you know, low-carb strip club.
Nice.
I'm trying to ruin his reputation while I'm here. It's what I do.
Oh, my God.
Ron does not go to strip clubs. Neither do I.
You know, interestingly, on that topic, in Boston, there was a very popular place called Legs and Eggs. I just want to leave it there.
We'll leave it at that.
Okay.
We'll leave it at that.
Okay.
What are your thoughts on sugar-free alternatives, quote unquote, says SS
I'm
Swift?
so glad somebody asked, because now we're finding those artificial sweeteners are actually probably a worse risk for diabetes than the sugar itself. And again, it's because of the impact on the gut microbiome.
Yeah.
So definitely, if I go to a hotel and they've got sweeteners versus sugar, I'll do a small packet of regular sugar over sweetener any day.
I'm the same way.
Totally.
Any day. People are shouting, Ron, says Kemi Rumeli.
Nice, okay, cool.
Yeah. He's handsome too, you know? I'm telling you.
Hey, one other thing I want to also add, because we talked about insulin resistance, is fatty liver, because we see so much of that. So when people can't process, when people cannot process carbohydrates adequately, often the carbohydrates will go to the liver to form fat, and we're seeing so much of that in kids and adults. And when your liver is full of fat, often it will be overproducing cholesterol, and it can't remove toxins from our environment very well, which means more inflammation. We're exposed to a lot of toxins through our environment. And when you've got fatty liver, we see that people struggle with weight loss, they've got brain fog, fatigue, etc. And again, the same dietary approach can cure fatty liver very quickly within months. So I recently did a very detailed blog post on fatty liver and how it works, but be aware of that condition, because in the US, 20 to 25% affected. Kids, probably about 18 to 20%. In parts of India, 40 to 60% have fatty liver when we've done studies. So it's really significant. Yeah.
And that again gets to this idea, I think, of skinny fat. Where are we putting this mysterious fat that we don't see? In the form of excess carbohydrates.
That's right.
And a grainitarian sort of approach.
Yeah, absolutely.
And it's going in the liver. It's going in the peritoneal fat.
You got it.
You don't see it. It's like an iceberg. You just see the tip of it.
Exactly.
And the rest is there. And that fat is particularly nasty.
It is.
Because it's inflammatory in itself. Some thoughts are.
Yeah.
And it's almost like an endocrine organ in itself. There's some thought of that.
Yeah, absolutely. You're right. Good stuff.
Did you guys have fun? I had a really good time. It was really a pleasure, Dr. Ron.
It's awesome talking to you.
Yeah,
You're doing great work. Yeah.
We've only scratched the tip of the iceberg.
Oh, literally. Yeah,
so literally. So I would love to have Dr. Ron back, and I'm glad we could spend the time that we did. We're straight out of Palo Alto. We're keeping it real. We were colleagues at Palo Alto Medical Foundation. It's great to reconnect with old pals and colleagues without the stress of having him admit somebody to me with fatty liver.
All right.
Or a massive MI.
Don't lose hope, guys. Okay,
that's the one
Anybody
thing.
can make changes with the right lifestyle moves. So
I love it.
Good luck to everyone.
All right, and there's no magic solution. You got to work. That's the other thing, right? We're not selling magic. We're not selling anything. All right, guys. Peace out. We love you. Peace.